Welcome to Course 6, Module 7 of the WHO training on the clinical management of COVID-19. This module is titled Rehabilitation for Patients with Difficulty Carrying Out Activities of Daily Living After COVID-19 Illness. The various difficulties patients may encounter following severe or critical COVID-19 illness, such as physical deconditioning, weakness, fatigue, breathlessness, and cognitive impairment can collectively impact their ability to conduct activities of daily living or ADLs. Depending on the level of severity of these underlying impairments, a patient may require assistance with basic self-care tasks such as eating, dressing, or bathing, or with more demanding activities like meal preparation, shopping, or domestic and work tasks. The guidance in this training module applies to the spectrum of activities that may be impacted and should be considered and applied according to the level of each individual patient. This training module provides occupational therapists and other rehabilitation professionals with information to guide assessment, planning, intervention, and monitoring of COVID-19 patients experiencing difficulty with conducting activities of daily living. This slide shows the WHO COVID-19 care pathway. Initial rehabilitation for COVID-19 takes place under the treatment stage. Rehabilitation may begin in the inpatient setting, including in critical care, and continue through ward-level care to inpatient rehabilitation, community-based care, or outpatient rehabilitation. Note that the release from pathway stage shown here refers to the end of transmission risk, not the end of rehabilitation and other care needs. At the end of this training module, you will be able to describe the different underlying factors potentially contributing to difficulties in carrying out ADLs in the context of COVID-19. Know who would benefit from an ADL assessment. Provide education and advice to patients and their families regarding ADLs. Provide energy conservation strategies, and describe potential environmental modifications to improve performance in ADLs. It is common for patients who have experienced severe COVID-19 to experience some degree of difficulty carrying out ADLs for weeks or longer as the ventilatory, metabolic, and cognitive demand of ADLs can exceed the capacity of patients experiencing respiratory, physical, and cognitive impairments. As mentioned, in the context of this module, ADLs include functional mobility, personal care such as dressing, bathing, or eating, domestic, work, and leisure activities. This module will take a closer look at the common rehabilitation approaches for people with COVID-19 that experience difficulty with ADLs. The content in this module may apply to an inpatient preparing for discharge or to someone that has returned to their home or community setting. It is not for patients in the ICU or a critical care setting. It is important to recognize how different impairments can impact performance with ADLs in order to provide appropriate education, advice, and interventions. Impaired lung function can result in dyspnea and dizziness with minimal exertion. When patients experience these symptoms, it can lead them to avoid activity, which is counterproductive to recovery. Weakness and physical deconditioning, common in patients recovering from COVID-19, can increase risk of falls and reduce exercise tolerance, while post-viral fatigue reduces energy available for activities. Cognitive impairment can also compromise safety with some activities, such as cooking or driving, that require planning, judgment, and problem solving. The overarching goal of rehabilitation is to optimize functioning and reduce disability and should always be targeted to the specific goals of the patient. However, in general, rehabilitation for patients experiencing difficulty carrying out ADLs aims to increase safety when carrying out ADLs, increase autonomy with ADLs, and improve quality of life. Specific infection control considerations related to rehabilitation for COVID-19 patients are based around the core principles of IPC: hand hygiene, respiratory hygiene, environmental cleaning, PPE, waste management. Please refer to the WHO IPC guidance and training materials for more information. This figure summarizes the rehabilitation cycle, which should commence with an assessment that can inform patient-oriented planning and guide treatment, with monitoring used to review and adapt plans as situations change. The following slides will address each phase in this cycle. ADL assessments are generally conducted to, first, establish the extent of the patient's capability to carry out different ADLs. Second, determine discharge readiness if they are still an inpatient. And third, establish support and assistive products requirements. The following patients should be routinely assessed for difficulties carrying out ADLs once they are medically stable. Patients that had been discharged from intensive care, older patients that have experienced severe or critical illness, patients that exhibit signs of difficulty with ADLs, or risk factors including breathlessness, reduced mobility, and cognitive impairment. ADL assessments are especially important for patients that are being discharged to environments with limited social support, including when supports have been reduced or suspended in the context of COVID-19 containment measures. The WHO International Classification of Functioning, Disability, and Health, or ICF, can serve as a module to capture and organize several constructs of subjective and objective assessment. As depicted in the figure, the ICF model highlights the way body structures and functions, health conditions, environmental and personal factors interact to impact performance in activities and participation. This concept of functioning and disability calls for an assessment approach that explores all these constructs. There are multiple sources of information that can contribute to an assessment of a person's safety and autonomy with ADLs. Observations, such as through a shower or tea and toast assessment, where a patient prepares a very basic meal, can provide valuable insights into how a patient's balance, strength, breathlessness, cognition, and other factors play out in a functional activity. It can also reveal the patient's confidence and awareness and use of strategies. Report from the patient themselves about what they can and cannot do, or what they find difficulty are important. However, be aware that patients may lack insight into their own difficulties, especially in the context of cognitive impairment, and it is common to hear conflicting reports from the patient and their family and from what behavior is observed. This is an important finding in and of itself, as insight into one's limitations is key to safety and ensuring that the patient uses the appropriate strategies and supports. Report from the family and nurses, caregivers should be gathered, and relevant background extracted from the patient's medical file. Prior to conducting an observational assessment, it is necessary to gather a holistic picture of the patient and their situation. Be sure to gather information on the patient's pre-admission ADL status, which is essential to determining the extent of their deterioration, their occupation and what activities they intend to return to, any comorbidities that may inform clinical decision-making and influence recovery, the patient's home environment, including accessibility and assistive products and social supports available at their discharge destination, and their current medical status. It is important to look across notes and talk to multidisciplinary team members, including physiotherapists, psychologists, and nurses, that can provide information on factors such as mobility, blood pressure, mood, and behavior. Wherever possible, use standardized tools to assess autonomy with ADLs that have been proven to be reliable, valid, and acceptable in your context. It may not be feasible or appropriate to conduct an observational ADL assessment in the acute ward due to time or limited infrastructure, and in such instances, it is best to derive as much information as possible from other sources and conduct an observational assessment following acute discharge as required. ADL assessments are most meaningful when they occur in an environment that reflects the patient's home so that a more accurate conclusion of how they will manage when discharge can be reached. However, patient safety should always be prioritized, and it is not advised to not remove environmental supports that the patient needs, such as grab rails or shower chairs, regardless of whether the patient has these at home. Results from assessments should be used to make decisions with the patient and their family regarding discharge readiness, support requirements, rehabilitation intervention required, including provision of assistive products, goals, and the mode of ongoing rehabilitation service delivery, such as whether inpatient, outpatient, community, or virtual service delivery would best suit the situation of the patient and be feasible in the context. When providing education and advice to patients, consider these key messages. Everything we do, including washing, dressing, and preparing meals, as well as work and play, takes energy. After a severe illness, they may not have the same energy, strength, or fitness they used to, and some tasks may take more time and effort than before. When they are very tired, breathless, or weak, even getting out of bed, washing, and dressing can be achievements. It is very normal to require additional support with ADLs after a severe or critical illness, and as they regain strength and fitness, their autonomy with ADLs will improve. And that it is important to become active again when recovering, but this will be a gradual process. Some patients will need to learn to manage breathlessness in order to effectively participate in ADLs, and advice on staying calm and using positions and breathing techniques are important. These are some of the positions that may reduce breathlessness. It is recommended that patients try them to see which one they find most helpful. Controlled breathing techniques can be used to help relax and control breathing. To try it, ask the patient to sit in a comfortable and supported position and put one hand on their chest and the other on their stomach, and to close their eyes if this helps them to relax. Otherwise, they can leave them open. They then need to focus on their breathing as they slowly breathe in through their nose or mouth if they are unable to do this, and then out through their mouth. As they breathe, they will feel their hand on their stomach rise more than the hand on their chest. They should try to use as little effort as possible and make their breaths slow, relaxed, and smooth. Advice regarding the management of breathlessness is also included in the WHO lung impairment training modules, and it is addressed in the WHO Support for Self-Management after COVID-19 related illness patient leaflet, which is available online. When patients have fatigue, they have limited energy reserves to allocate to activities. Especially when fatigue is severe, they will need to conserve as much energy as possible when performing tasks and adapt how they go about their day. The following are strategies that help patients conserve their energy and better manage their fatigue as they recover. Advise patients to adjust their expectations for what you can do in a day. Especially in the early days and sometimes weeks following discharge, activity levels should be kept low. They should save energy by doing tasks sitting down when they can, such as when showering, dressing, or preparing food, and avoid tasks that require extended periods of standing, bending down, reaching high, or squatting. They should try to pace themselves and to do lighter tasks between heavier ones. They may also need to leave themselves time during the day to rest. Encourage them to let others help them with tasks that they may be struggling with. Things like caring for children, shopping, preparing meals, or driving may be difficult for some time. Finally, they should ease back into activities very gradually and not attempt to resume their full activities until they feel ready. This includes when a patient is returning to work, where they may need to begin with half days, a few days a week, and extend their hours as they are able. When it is possible, those with physically demanding jobs should seek alternative duties temporarily. Environmental modification can compensate for loss of function, increase autonomy, conserve energy, and improve safety. They may consist of provision of assistive products such as shower chair, over toilet frame, bath board, mobility device, or long-handled aids for washing and dressing. Consider whether these require arm rests and back support based on the status of a patient's sit-to-stand transfers and seated balance. Installation of grab rails or bars in areas like the shower, bath, or toilet. Installation of handrails along stairs. Increasing ventilation in bathrooms or showers to assist with breathing. And rearranging items, such as in the kitchen, so that they are between the heights of patients' hips and shoulders to avoid reaching and bending. Use assistive products that are quality approved and ensure any bars or rails are installed correctly so that they don't pose a false risk. Everyday plastic can corrode when exposed to heat and water and may not safely support a person's weight, especially when their transfers are not well controlled. In some contexts, after a person has been severely or critically unwell, it is normal for family members to assist with ADLs, even beyond what they may be required, and independence may not be a desired goal. The need to respect this cultural practice should be carefully balanced against the need to encourage the patient to gradually become more active as part of their recovery process. It is important to include the patient's family or caregivers when providing education and advice so that they know how they can best support the patient's recovery. Some built environments are less accessible for people with reduced mobility, such as those that use squat toilets or that have stairs. In such instances, innovative solutions may be required, such as moving a sleeping area downstairs if a patient cannot manage stairs, or adapting squat toilets to include frames or grab bars. A patient's ability to carry out ADLs will inevitably improve as the underlying impairments hindering their performance are addressed. Guidance for rehabilitation in the context of physical deconditioning and weakness, lung function, and cognition can be found in the respective modules within this course. It is useful to work closely and communicate frequently with other rehabilitation professionals that may be engaged in the patient's recovery, as participation in ADLs are also important opportunities for incorporating and practicing exercises and strategies that target these impairment areas. The need to repeat ADL assessments over time depends on how the patient is progressing. Assessment of self-care activities may not need to be repeated if the patient is reportedly safe and performing at the same level they were pre-admission. If challenges persist, however, repeated assessments may be useful in monitoring what progress is being made and what new strategies can be applied. Assessment of different types of ADLs may become necessary as the patient recovers. For example, while initially self-care activities may be the focus, domestic, work, or leisure activities may need to be assessed as the patient becomes more active. When collecting data on patient progress, consider who it should be shared with, such as a general practitioner, considering local rules and protocols regarding patient confidentiality. Adapt the rehabilitation plan based on the results of monitoring. This could result in increasing or downgrading the use of personal or environmental supports, amending interventions such as introducing new strategies or providing education and advice to address specific challenges not adequately covered, referring to different services such as return-to-work programs where they exist, or ceasing rehabilitation when patient has plateaued and there is no further benefit to be achieved. In summary, when working with a COVID-19 patient population, remember that most patients who have had severe or critical COVID-19 will have some degree of difficulty with carrying out ADLs, and their function may be significantly impaired initially. Performance in ADLs will generally improve over time, but may persist. Rehabilitation for ADLs encompasses education and advice, strategies for energy conservation, techniques for managing breathlessness, and environmental modification, and that the mode of service delivery should enable maximum participation and consider barriers to attendance. The patient leaflet referred to throughout this module can be found via the first link on this list. The Clinical Management of COVID-19 Interim Guidance has a dedicated chapter on rehabilitation, and it is advised that rehabilitation professionals review this as well as other relevant sections relevant to their scope of practice. It highlights the importance of routinely assessing patients for functioning difficulties, providing rehabilitation in a range of settings, and the importance of multidisciplinary care that is tailored to individual needs. The Rehabilitation Considerations document has a focus on higher-level recommendations, but provides a useful overview of the impact of COVID-19 on rehabilitation service delivery. It includes an overview to the management of patients with severe COVID-19 and suggestions for how rehabilitation services can be delivered considering infection prevention and control measures. That concludes this training module. These people contributed to the content and they are highly acknowledged here.